next presentation is Female Gender is Associated with Worse Outcomes Following Complex Fenestrated or Branched Endovascular Aortic Repair by Brendan Gontars and colleagues from Connecticut as well as the Mayo Clinic.
Thank you. Good morning. My name is Brendan Gontars. I'm one of the fourth-year surgery residents from the University of Connecticut, as well as a current applicant in this year's match process for vascular fellowship. Thank you for allowing me to present. Here's some relevant disclosures. The complexity of vascular disease that can be managed endovascularly, particularly aneurysmal disease, continuously expands with each new generation of stent graft. With the increased complexity of this disease and these procedures, so increases the risk of complications, both perioperative and long-term. Outcomes after standard EVAR are noted to disproportionately affect females. They experience longer operative times and more access vessel complications. There's a growing body of literature that shows similarly poor outcomes and even mortality in females after complex fenestrated and branched endovascular aneurysm repair. Although a recent publication from a consortium of high-volume aortic centers shows similar mortality between the genders, whether similar results extend to real-world practice on a national level is unknown. Our objectives are to examine the difference in preoperative demographics and risk factors between the genders after elective fenestrated branch EVAR. We sought to determine if females experience differences in outcomes following repair of complex aortic aneurysms in regards to target vessel failure, reintervention, complications, and in-hospital mortality. We did this by performing a retrospective review, querying the Society for Vascular Surgery's VQI database from January 2012 to December 2020. We used to standardize our population. We included all juxtarenal through type 4 thoracoabdominal aneurysms who underwent elective fenestrated branch EVAR with proximal sealing in zones 5 through 8. Urgent, emergent, symptomatic rupture and stage cases were excluded, as were patients who had genetically triggered aortic disease and patients with parallel stent grafts. The VQI database does not specify centers as high volume. Thus, we chose to define high volume center as centers in which 5 or more fenestrated branch EVARs were done per year over our study period. And then we defined target vessel failure as a composite of unintentional target vessel coverage, intraoperative occlusion, or postoperative stenosis of greater than 50%. We performed a univariate analysis comparing the genders based on their demographics, preoperative risk factors, comorbid conditions, technical and operative factors, as well as their postoperative outcomes. Then, using preoperative demographics and risk factors, we constructed a multivariate logistical regression looking specifically at target vessel failures, in-hospital reinterventions, any complications, or in-hospital mortality. We chose to look at immediate outcomes, thus data was limited to the index operative admission, i.e. no follow-up data. Our inquiry resulted in 1,991 patients. 77% were male and 23% were female. In our female cohort, we noted they were older, more likely to have COPD and be current smokers, and they were less likely to be on preoperative aspirin and statin therapy. Our male cohort had higher BMIs, high rates of cardiac disease, most notably CAD and CHF, more likely to be in preoperative assisted care. Men had larger aortic diameters and were more likely to have prior aortic surgery, and also men were noted to have their procedures more frequently at these high-volume centers. Women appeared to have more complex and challenging operations, and this was supported by longer fluoroscopy times, longer total procedure times, higher volumes of contrast used, higher estimated blood loss, and more likely to receive an intraoperative transfusion. Access also appeared to be more challenging in females, with lower rates of percutaneous access and subsequent higher rates of combo open and percutaneous access, as well as open femoral access or iliac conduits. The number of custom modified endografts in the rate of custom modified endografts in each group was similar at 61%, as was the number of fenestrations and rate of interventions on target vessels and rates of technical success. Between the genders, both groups had similar frequencies of proximal sealing in zones 5 through 8. In our outcomes, intraoperative outcomes appeared to disproportionately affect females. They had higher rates of converting to an open procedure, higher rates of access site arterial injury, and higher rates of target vessel failure, most notably in the celiac and renal arteries. Rates of immediate endoleaks did not differ between the genders. In regards to any complications, again, females were disproportionately affected with high rates of complications overall, including leg embolization, intestinal ischemia, renal ischemia, spinal ischemia, surgical site infections, respiratory failure, dialysis, stroke, and dysrhythmias. Females experienced higher rates of reintervention during that index admission overall. However, it should be noted that access site reinterventions was not higher among females. Finally, the length of stay was longer in women, as well as higher rates of discharge to a facility, and mortality was significantly higher among females at 5.6% compared to just 1.9% in males. During our multivariate logistic regression, we noted that female gender was an independent predictor of target vessel failure, as was hypertension. Female gender was also predictive of reintervention, as was ASA class 4 and having a procedure at high volume centers. Female gender was again predictive of any complications, as was age, ASA class of 4, and COPD. And finally, mortality was again associated with female gender, as was COPD. Procedures at high volume centers were associated with an increased risk of reintervention. However, they were not associated with increased rates of complications or in-hospital mortality. In summary, females experienced worsened outcomes, most notably mortality, after complex fenestrated and branch EVAR, despite similar extent of disease, similar frequencies of proximal sealing zones 5 through 8, and similar number of fenestrations. Notable discrepancies in females were older age, increased rates of COPD and current smoking, lower rates of preoperative aspirin and statin therapy, and lower frequencies of procedures at high volume centers. Females appeared to have more challenging operations with longer operative times, higher blood loss, and more likely to receive an intraoperative transfusion. Controlling for these demographics, female gender was an independent predictor of poor outcomes. Our cohort likely represents a population reflective of real-world practice outside of an ID study. Although the etiology of these discrepancies is unclear, data suggested by our analysis shows that preoperative pulmonary status, aspirin and statin therapy, as well as target or access site and target vessel anatomy as potential contributors. And the preoperative evaluation in these patients should include a low threshold for alternative access, conduits, and low-profile devices. These discrepancies warrant further investigation and should impact preoperative planning and postoperative care in female patients undergoing complex aneurysm repair. Thank you for your time, and I welcome any questions or comments.
Thank you for that presentation. I might have just missed it, but did you look at the females who did poorly versus the females who didn't have any issues, and then try to identify factors that would be predictive of worse outcome, and then you could find something you could not do in people to prevent?
Yeah, so we did actually do that. We did a second analysis. When we started working on it, we actually realized that could potentially be its own separate paper. Our analysis showed that we didn't include it in here, but we showed females ASA class of 4 did worse, and females that were older did worse. And then I think one of the most striking things was the intraoperative factors related to poor outcomes. So longer operations, higher blood loss, more contrast, and higher rates of transfusions, all related to poor outcomes. So I guess the one thing that we haven't quite identified yet is what preoperatively can you do to limit what intraoperatively would cause those subsequent issues.
Yeah, I would also wonder about anatomical features that might, preclude you from doing an endovascular repair versus open in these people.
That's also, sorry, just to add, with the VQI, it's sometimes difficult to parse that out. We don't have, detailed anatomy on the iliac system or angulation or aortic neck, so that would definitely be something to look at.
No, I think that's an excellent point. And first of all, I want to congratulate you on your talk. Very interesting and good job of pointing this out. And obviously, outcomes across the whole country are going to be different than extremely high volume centers. We do know, however, as you pointed out, that high volume centers can do this and do this really well. And there is definitely a learning curve. So I know you dichotomize by high volume center being greater than 5 cases, and that's something, but what you could look at is center volume effects. With increased volume, maybe it's not 5, maybe it's, there's a continuation of effects. And the other major thing is that we know that in patients who get FEVAR, one of the major risk factors for interventions, you pointed this out a little bit, was the renal arteries. And it's probably due to their smaller size than the celiac and SMA. And so we also know that women have smaller visceral renal arteries than men. And in VQI, you actually have access to the branch vessel sizes. So one thing I would encourage you to look at in your paper is the size of the smallest target branch. And if that was correlated with, this negative outcome in reinterventions, which I would almost guarantee it is, and then also center volume effects. Thanks.
Thank you. Appreciate it.
Hi, very nice presentation. I'm Jeannie Ruddy from the Medical University of South Carolina. I was curious whether you did any subset analysis based on the extent of the aneurysm, because you said you included everything from juxtarenal to type 4 thoracoabdominal, which of course, as people have commented on other components of anatomy, that anatomy of the aneurysm itself would influence some aspects of the procedure. And it may actually be more prospective for a provider to be able to look at a person as a female sex thoracoabdominal type 4 or female sex juxtarenal and understand how there's a difference there in the morbidity and mortality risk.
Yeah, we did compare the frequencies of the type between the genders. We did not break it down as far as outcomes. We just kind of report them as frequencies between the two. But we could definitely look at the outcomes of certain type of aneurysm fared worse than others.
Yeah, just to follow up on that question, I think the simplest way to do the analysis, probably with the data you have, is just separate the zone 5 seals versus zone 6, 7, and 8. And then that would then probably give you the idea of something that's a short neck infrarenal versus a thoracoabdominal. My question was, since you made the comment, this is real world and outside of the IDE team folks, in the zones 6, 7, and 8, what devices do you think people are using then that is real world?
Yeah, so that's a great question. Unfortunately, in the VQI, from my understanding, it gives codes and identify, but it doesn't identify the specific type of device. So unfortunately, I don't have from my data set the granular data to exactly answer your question. And on a personal level, I just at this present time don't have the expertise to comment on that. However, I'm eager to enter a fellowship that will be willing to teach me that. So I'll leave that as my final plug. Thank you.
Thank you very much.